Hello everyone, myself Dr. Kajal Goswami. Today we are going to learn practical aspects of spirometry, which is a method to measure lung volumes and lung capacities. Lung volumes and capacities are broadly divided into two, static and dynamic. Static lung volume and capacities are those which are not dependent on time. Examples of static lung volumes are tidal volume, expiratory reserve volume, inspiratory reserve volume, residual volume. And examples of static lung capacities are inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. Dynamic lung volume and capacities. They are time dependent. Examples are forced vital capacity, forced expiratory volume, respiratory minute volume, and peak expiratory flow rate. This is the image of Hutchinson's spirometer. This is made up of two chambers, one outer chamber and one inner chamber. The outer chamber is called water chamber as it is filled with water. The floating drum is immersed in water in inverted position. A drum is counterbalanced by weight. A mouthpiece is attached to the rubber tube. This is the graphical representation of the different static lung volumes. Here we can see this is the tidal volume which represents the normal inspiration and normal expiration. The inspiratory reserve volume is the maximum inspiration which can be done after normal inspiration. The expiratory reserve volume, it is the maximum expiration which can be done after normal expiration. And the residual volume, it is the amount of air which remain in the lungs even after forceful expiration. Now let's see how to perform practically. First we will see the tidal volume. It is the amount of air that can be inspired or expired normally. The normal value of tidal volume is around 350 to 500 ml. To perform, set the spirometer on 0. Ask the subject to take normal inspiration through mouth and then expire normally into the mouthpiece with nose closed. Now let's see how to measure expiratory reserve volume. It is the volume of air that can be expired with maximum efforts after normal expiration. The normal values are 750 to 1000 ml. How to perform? For that, set the scale on 0. Ask the subject to expire normally outside. After that, expire into the mouthpiece of the spirometer with maximum efforts and nose closed. Now let's see how to measure inspiratory reserve volume. It is the amount of air that can be inspired with maximum efforts after normal inspiration. The normal value of inspiratory reserve volume are 2000 to 3200 ml. How to perform this? For that, set the scale on 4 liter mark. Ask the subject to inspire normally and then inspire with maximum efforts into the mouthpiece of the spirometer with nose closed. The difference between these two readings is our IRV reading. Now let's see how to measure vital capacity. It is the volume of air that can be expired out with maximum efforts after maximum inspiration. The normal value is 3200 to 4800 ml. How to perform this? For that, set the scale on 0 and take maximum inspiration from the outside. Expire into the mouthpiece of spirometer with maximum efforts. Residual volume, it is the amount of air that remain in the lungs even after forceful expiration. The normal value is around 1200 ml. The residual volume cannot be measured by spirometry. Now let's discuss some lung capacities. This can be calculated by adding two or more than two lung volumes. First, we'll see the inspiratory capacity. It is the maximum volume of air that can be inspired after normal expiration. Inspiratory capacity equals to tidal volume plus inspiratory reserve volume. Second is the functional residual capacity. It is the volume of air that remain in lung after normal expiration. FRC equals to expiratory reserve volume plus residual volume. Here we should know the difference between the residual volume and functional residual capacity. Residual volume is the volume of air that remain in the lung after forceful expiration, and FRC is the volume of air that remain in the lungs after normal expiration. Third one is the vital capacity. It is the maximum volume of air that can be expelled out forcefully after deep inspiration. Vital capacity equals to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. The fourth one is the total lung capacity. It is the volume of air present in lungs after maximum inspiration. Total lung capacity equals to inspiratory reserve volume plus tidal volume plus expiratory reserve volume plus residual volume. Or we can say that total lung capacity equals to vital capacity plus residual volume. Spirometry cannot measure residual volume, functional residual capacity and total lung capacity. It can be measured by helium dilution method, nitrogen washout method and plethysmography. Now let's see maximum breathing capacity. It is a dynamic lung capacity. It is the amount of air that is breathed out with maximum efforts in 1 minute. A Douglas bag is used to collect the air which is measured at the end of 1 minute. The normal value is 82 to 170 liter per minute. Next is respiratory minute volume. It is the normal amount of air breathed in and out in 1 minute. It is calculated by tidal volume into respiratory rate per minute. That means 500 ml into 12 per minute equals to 6000 ml per minute. Clinical significance of spirometry. Spirometry is used to diagnose asthma, COPD and other conditions that affect the breathing. Spirometry may also be used periodically to monitor your lung conditions and check whether the treatment for chronic lung conditions is helping you breathe better or not. FEV1 is very much decreased in obstructive disease like asthma, chronic bronchitis, emphysema and cystic fibrosis. FEV1 remains same or slightly reduced in restrictive disorders. Now let's discuss respiratory efficiency test. Efficiency tests are done to assess the ventilator functions of the lung. These are vital capacity, respiratory minute volume, maximum breathing capacity, breath holding test, expiratory pressure and 40 mm endurance test. Amongst these, we have already discussed vital capacity, respiratory minute volume and maximum breathing capacity. Now we'll discuss the breath holding test. For breath holding test, ask the subject to expire normally and hold his or her breath. After that, determine this maximum time up to which subject can hold his breath. There will be one breaking time when subject cannot hold his breath. This is due to the accumulation of CO2 in the blood. It will stimulate the respiratory centers and subject need to inspire. The normal value for breath holding test is 45 seconds to 1 minute. Next is the expiratory pressure. To measure the expiratory pressure, connect a rubber tube and mouthpiece to the sphygmomanometer. Take deep inspiration and apply nose clip. Blow into the tube and pushing the mercury column up. The maximum reading will be the expiratory pressure. Normally it is about 100 mm of Hg. Next is 40 mm endurance test. To perform this test, inspire deeply and apply nose clip. Blow into tube of sphygmomanometer and take mercury column up to 40 mm. Note the maximum time up to which mercury column can be held steady at the 40 mm of Hg. Count the pulse rate along with it, so when pulse rate increases, the procedure can be stopped. Normally it is around 50 seconds. Now let's discuss few Viva related questions. First is, what is the effect of posture on vital capacity? The vital capacity is more in erect posture than the sitting or sleeping position. The reasons are that in erect positions there is more muscular efforts applied. A diaphragm descends, so capacity of thoracic cage increases. An effect of gravity. In supine position there is elimination of effect of gravity. So blood flow to the lung increases and decreases the vital capacity. In erect position there is an effect of gravity. So blood is pulled to the lower limb and pulmonary blood flow will decrease. So vital capacity will increase. Next question is, which are the conditions where vital capacity is reduced? First we'll see the physiological factors. First is posture. It is less in sitting and lying position than the erect postures. Then the age, low in children and old people as compared to adult. Then the sex. It is less in females as compared to male. Then the physical build. It is low in thin as compared to obese. Then the pregnancy. It will reduce due to the chest expansions. And then physical training. It will lower in untrained person than the trained person. Pathological conditions which can reduce the vital capacity are disease of chest wall like kyphoscoliosis, lung disease like emphysema, fibrosis, pulmonary edema, pleural disorders like pleural effusion, pneumothorax, or abdominal disorders like tumors and ascites. Next question is, what is the significance of FRC? FRC maintains a constant residual volume and allows continuous exchange of gases in both the phase of respiration. It checks the sudden fall in partial pressure of gases in blood, measured by helium dilution and nitrogen washout method. FRC increases in condition in which air trapping occurs like emphysema and asthma.